Hello, this is Michelle from PhysioActive Indonesia, bringing to you another episode of Singapore Surgeon Insight series. Today, joining us is Dr. Ramesh Subramaniam, Specialist Orthopedic Surgeon from Avant Orthopedics, Singapore. Doctor, can you tell us about your qualifications and specialities?
So I'm an orthopedic surgeon practicing here in Singapore. I did all my training in orthopedics here locally. I've got a special interest in sports injuries, predominantly involving the shoulder and knee. After finishing my training here in Singapore, I spent 1 year in Ireland working over there. We were very involved in treating injuries seen in rugby players and Gaelic football players over in Ireland. And following that, I spent half a year in Barcelona, Spain, where we were also looking after all the footballers who had football injuries and knee and shoulder injuries as well. I've been back in Singapore practicing here since 2012. I worked as a consultant with a public hospital for about 4 years. And since 2016, I'm in private practice here in Singapore at the Ma Elizabeth Novena Hospital. The bulk of my work involves treating patients, both athletes as well as recreational athletes, for their injuries. And we also treat other patients who have shoulder and knee problems in my practice as well.
Today, we will be addressing a knee issue commonly caused by sports injuries, the anterior cruciate ligament repair and reconstruction, also known as the ACL repairs and reconstructions. Doctor, can you explain to us a bit about the ACL? How important is this ligament?
So the ACL is a ribbon-like structure that is found in the knee. It connects the thigh bone to the shin bone. It is a rather important ligament because it controls the stability of the knee. It prevents the knee from sliding forward and backward. It also prevents the knee from rotating. Now, when in the course of sports or in the course of a fall, some patients may rupture this ligament. When that happens, the knee usually swells up with a lot of fluid and it gets very swollen and painful. And very often, this ligament needs to be reconstructed surgically. If surgery is not done, then these patients usually complain about instability, where the knee seems to buckle on them or give way. So for that reason, most of us would recommend these patients go for minimally invasive surgery to reconstruct the ACL so they can get back a good functional knee.
Can a torn ACL heal on its own?
A torn ACL has got low chance of healing. And the reason for that is because the blood supply of the ACL runs on the fibers itself. So when the fibers rupture, you tend to also disrupt the blood supply. And if the blood supply is disrupted, the ligament cannot heal. There are instances where sometimes the ligament is torn partially, or if it's torn, the blood supply may still not be too badly compromised. In those situations, the ligament may scar down. But even if that happens, what has happened to the ligament is that the tension in the ligament has been lost. So even though the ligament may look functionally intact, it doesn't have sufficient tension. As a result of that, the patient may still feel the symptoms of an ACL injury, such as instability or giving way. So a short answer is that it doesn't heal most of the time, which is why a lot of these patients end up requiring surgery.
Are there any particular symptoms one should look out for when they have an ACL injury?
Okay, so the approach to these patients with ACL injuries usually starts with the story of what happened. So I get a gauge of what kind of a person this patient is. Is he super active? Is he doing a lot of sports? If he's doing sports, what kind of sports is he doing? So for example, certain sports where the knee undergoes a lot of twisting and turning, like soccer, basketball, rugby, skiing, these are the common sports where there's a lot of pivoting of the knee or twisting of the knee. And these particular sports, there's a very high risk of getting ACL injuries. So I'm trying to find out a bit more about the profile of the patient in terms of how old they are, what kind of sports are they doing? Are they doing it at a very competitive, high level, or are they playing recreationally, and what their requirements are? So after we find out a bit more of the patient and their profile, we then ask about the knee. And usually the patients give a story that, they were playing football, and there was a sudden twist and they felt a crack sound in the knee or a pop sound or a snap sensation in the joint. And that usually means the ligament has given way. Now, when that happens, the blood supply is disrupted, so the knee bleeds excessively. So what they develop almost instantly is a huge swelling of the knee joint. So the entire knee becomes filled with blood. So then they're unable to carry on playing. They have to be either stretchered out or they're limping out of the game, and they can't walk properly and they're usually on crutches. So these kind of patients usually end up with a doctor or the hospital. And when they come in, usually we examine them. We will do an MRI to clinch the diagnosis of injuries inside the joint. Once we have diagnosed that this is indeed an ACL injury, we would then offer the patient treatment to reduce the swelling first. So, for example, aspiration of the knee and icing of the knee. And then there's a discussion about surgery at a later stage. So in approaching the patient, besides getting the story right about how they injured the knee, the examination, we're also looking for how swollen the knee is, whether there are any other ligaments or any other signs of injury around the knee, because some of these injuries can be quite nasty and the patients can also sustain a fracture. So we also look for the bones to make sure that the bones are not injured. So once we have done the physical examination, I think in this day and age where MRI accessibility is quite common for most hospitals and doctors, it'll be imperative to get an early MRI so we can diagnose the problem very clearly and we can have a discussion with the patient about what the injury is and what the next steps are. In terms of tackling an ACL injury and treating it, there are two schools of thought. Some doctors prefer to do the surgery early. That means within a few days of the injury, they will try and reconstruct the ligament. And the other doctors prefer to do it at a delayed setting, possibly about 4 to 6 weeks later. It depends on the profile of the patient. If this particular person who injures the ACL is a very high-level athlete or is a career athlete, which means that his sport is his career, we don't want to let them have too much downtime from their sport. So we would then encourage them to get the surgery done earlier. But if this patient is a recreational athlete and you know this patient's got time, then it may be better to let the swelling and the inflammation around the knee settle down. And once the swelling and the inflammation is better, then we do the surgery in a delayed setting about 6 weeks later.
So what would the surgery entail, doctor? Perhaps you can give us a brief explanation on the procedures involved.
Okay. So ACL reconstruction surgery is a minimally invasive surgery that's done through an arthroscopic method. So arthroscopy means we make small incisions, no bigger than a size of 1 cm, and we insert a camera into the joint. And by inserting a camera into the joint, you can have a full spatial visualization of the joint to be able to diagnose the injuries and as well as do the surgery. The entire surgery is done under full anesthesia. It takes about 1.5 to 2 hours to do the procedure. We need to put in a new ligament to replace the ACL. Because the ACL fibers are torn, we will need to put in a new ligament to replace the torn ligament. So the first initial discussion with the patient is, where do we get this new ligament from? That's the question that all the patients will ask. Well, there are a few options. The commonest source of this new ligament is actually to use the patient's own hamstring tendons. So on the same leg, we can harvest 2 of the hamstrings, and this can also be done through a very small incision, no bigger than 3 cm, and we can use those tendons and tunnel it through the joint for it to become the new ligament. So we make tunnels in the bone, and we send the tendon through the tunnels into the knee joint, and usually we anchor it with screws or a rope. And what these devices will do is you will fix the ligament into the bone such the ligament doesn't move, or rather the tendon doesn't move. And over the next 6 to 8 weeks, as the tendon matures, it will become the patient's new ligament. So hamstring tendons are by far the commonest graft that's used here in Singapore. There are other grafts that are used as well, and usually, depending on the profile of the patient, we will then discuss this. A second alternative is to use a patient's own patella tendon graft. So if you look at the knee, if this is the knee joint, this is the patella, which is the kneecap, and there's a tendon that we can use right down the front. So this tendon is a big beefy tendon and comes with bone at either end, and this bone plugs allow better healing and faster healing. So if I were to see a club level footballer or an elite athlete or a career professional footballer, then I think using a bone patella tendon may be a better option for these patients because it's a much thicker, bigger graft, and also the healing is a little bit faster. The third option, which is quite common, is to use something called allograft. Allograft means these are tissues that we don't take from the patient. This is taken from a different patient or a donor tissue. So there are various tissue banks that we have access to, and these tissue banks keep these allografts in there. So these ligaments or these tendons are procured from other patients, and they're usually kept in a sterile manner. So we can use this to implant into the patient's knee to perform like the ACL ligament as well. And allograft usage is becoming fairly popular because a lot of patients don't want their own tissues to be taken, or they don't want their hamstrings to be weakened. So then they would say, can you just use an allograft because I don't want my tissues to be taken. So I think in our practice here in Singapore, the commonest grafts we use are the hamstrings and the bone patella tendon, which are called autografts because they're taken from the patient's own body. And the other alternative is to use allograft. There's a new graft that's being used that's becoming fairly popular as well. It's called the quadriceps tendon. So this is the graft just on top of the kneecap. It's also taken from the patient's own tissue. This has been getting fair popularity around the world in various centers. And for some patients, if they're suitable, we use this graft as well. So the first discussion about the patient is which graft to use, because that will determine where the incisions are going to be made and what they can expect from the surgery. So after the graft is harvested, we would then prepare the graft. We will make the tunnels in the bone guided by our arthroscopy instruments inside the joint. We will then pass the graft through the tunnels, and then we'll fix it on either end with screws. So by fixing it, the graft is stabilized within the joint under tension, and that will then give the patient a new ACL as the patient recovers. So post-surgery, normally we put an ice pack on the knee to let the knee swelling be resolved, because during surgery, the knee gets a bit swollen because of all the fluid going in for the arthroscopy. So we put an ice pack to reduce the swelling. We also give the patient a knee brace. This is to help stabilize the joint, because for a lot of these patients who undergo ACL surgery, there's a fair bit of muscle deactivation around the joint. Right. So when they start walking, they feel the knee is not so stable. So for that reason, we always like to put a knee brace around the knee to give them better stability. Almost 80-90% of them may require crutches for the first 1 to 2 weeks, but within 1 to 2 weeks, the muscle activation comes back. A lot of them find that I don't need the crutches, so then they can walk without crutches. The full healing of the wounds is about 2 weeks. The full healing of the graft is about 2 months. But for these patients to be able to go back to running, it will probably take them between 4 to 6 months. And usually back to football or sports of that nature is usually about 10 months to a year.
Okay, so that's quite clear on the downtime. Thank you for that. Doctor, for Indonesian patients that want to plan their travels or their itinerary, how long should they be looking to stay in Singapore for a post-checkup, for the surgery? What's the overall itinerary going to look like for them?
Okay, so because this is a minimally invasive surgery, in terms of risk levels, it's not as risky or as major as, say, doing a joint replacement surgery. So normally we recommend these patients who come from overseas to come to Singapore at least a few days before the surgery, so that we can examine the knee and make sure the knee is ready for the surgery. Now, it would be not good to do a surgery on a knee which is still very inflamed, or if the knee doesn't get full range of motion, then we shouldn't be doing this surgery. Which is why it's my preference to always send all my ACL patients or the patients with ACL injuries to a physiotherapist first for a period of what we call prehab. Prehab refers to the physiotherapy that they get before the surgery. And this is a very, very important part of ACL reconstruction surgery and subsequent success. So what the patient will focus on in prehab with the physio is to get a good range of motion of the knee, especially extension. We want the knee to get full extension. And we also want the soft tissue envelope around the knee to be quiet. It means we want all the inflammation and swelling to be down. Because studies have shown if this knee is still in a very inflamed state, and if I were to do any surgery on the knee, there's a very high risk the knee will be stiff post-surgery. So for that reason, it's imperative to make sure that there's inflammation around the knee is resolved. So for these patients, even before they come to Singapore, if they are liaising with me, I would recommend they get a period of prehab back in Indonesia or whichever country they're coming from. So that when they get on the plane, they come to Singapore, the knee is ready for surgery. So it's good to assess them 1 to 2 days before the surgery to make sure that the knee is ready for surgery. Now, post-surgery, they should be able to fly back within 3 to 5 days. The pain will be much better within 3 to 5 days. I'll usually review them in my clinic to make sure the incisions are healing well, the swelling is much better, their pain levels are under control before they can fly back. If you're talking about parts of Indonesia which are within 1 to 2 hour flight away, it's not a problem. But if it's any other neighboring country which is more than, say, 3 hours away, I would usually not recommend they fly within the first 2 weeks, because the concern there is venous thrombosis of the calf muscles when they fly. For a long-haul flight, some of these patients after knee surgery can develop venous thrombosis. So if they can afford the time and they are able to make arrangements, then I would recommend that they stay in Singapore at least for the first 2 to 3 weeks before they fly back, if their destination is further away from, say, 1 to 2 hours by flight. So that 2 weeks in Singapore gives me enough time to take a look at their wounds, to also remove stitches for them, and to make sure they're walking fairly well without crutches before they fly off. If they were to fly within the first 3 to 5 days post-surgery, then it's very likely they need to fly with crutches. And that can sometimes be a hassle when they're flying in terms of boarding and alighting from an aircraft. So it's better for them to fly without the crutches, and a usual time period for that is about 2 weeks.
Okay, and for the post-op, would they need a physio or rehabilitation, a specific rehabilitation program for a period of time?
So, Michelle, you're absolutely right. Rehab is a key part of this overall ACL surgery success, and I cannot stress that enough with my patients. So before I make a patient sign on the dotted line for surgery, I will get their verbal promise that they will have to go for rehab. Because if you think about it, my intervention for the knee is only about 60 to 90 minutes. That's how long I take to finish the ACL job. But the rehab is up to a year. So they can't go for surgery for 1 hour and neglect the rehab and get a very stiff, non-functional, weakened knee. So it's very important that they comply with the physiotherapy program. So there are a lot of therapists that I work with, both here in Singapore and over in Indonesia as well, to make sure these patients are well taken care of post-surgery. Most ACL patients will follow an ACL rehab protocol. And these days, we have refined the protocol to come up with a more accelerated rehab protocol for them. So this protocol very clearly states week by week what they should be doing and also what milestones they should be achieving. So if the patient is seeing their physio or patient is seeing their own physio, normally I send the protocol together with the patient so the physios will understand what the patient needs to do in the physio sessions. I also encourage every physio to have an open line of communication with myself, either through WhatsApp, phone call, or email, so I can get an update on this patient every month or so. So I know monthly whether the patient is moving along and whether the patient is meeting the milestones in terms of rehab. If I'm not getting sufficient movement of the joint and the joint is stiffening up, then I want these physios to send the patient back to me earlier, so there are things that I can do for the patient to move them along. So constant to and fro communication between the surgeon and the physio is very important throughout the patient's entire rehab journey through ACL recovery. But I'll stress again, physiotherapy and rehab is very important for anybody considering undergoing ACL surgery.
Okay, thank you. And doctor, do you have anything else to add for our viewers? Any extra information?
So ACL surgery over the years has undergone lots of design changes, lots of trends. Just to mention a few trends that have come and gone. At one point, people were trying to repair the ACL ligament, but the early studies coming out of these repair surgeries said that ACL repairing results were not so good. So everybody moved towards doing ACL reconstruction. Repair meaning you reattach the torn ligament. Reconstruction means you put in a new ligament. So people were doing repairs before, the results were not so good, so people moved towards reconstruction. But now there's a lot of scientific research coming out saying that for certain patients, you can attempt to repair them. So patients who tear the ACL from the upper end, and if they're young patients, you can stitch it back and it can heal to some extent. So there's a lot of interest in doing ACL repairs again. So that's a trend that's coming on, and most of us are offering that to our patients as well. There's a second trend which involves the anatomy of the ACL. Now, as we studied more about the ACL ligament, we realized that there's not just one bundle of fibers, and actually the two bundles that are wrapped together. So they call it the AM or anteromedial bundle and the posterolateral bundle. So there are some surgeons who are doing two bundle reconstructions. That means they put two grafts or two tendons in there to do each bundle separately. And then there's a lot of research in science showing that, even though biomechanically it's good, results-wise, patients were doing the same. So everybody kind of moved back to doing just a single bundle now. There are still centers with double bundle, but we find that single bundles work well enough for our local Asian population.
Okay.
And then now there's another trend as well to put an additional ligament when you do ACL surgeries on the outside of the joint, what they call an anterolateral ligament or a lateral extra-articular tenodesis procedure. And putting a ligament on the outer part of the joint, that means instead of putting it inside the joint here, you put the ligament on the outer part. It helps to stabilize the joint even further. Mm-hmm. So for patients who are high risk of re-injury, like those who are playing football or those who are doing a lot of skiing or those who have hyperlaxity or those who have a lot of twisting of the knee when you examine them, for these patients, there's a lot of research and data coming out showing that you may want to consider doing a external ligament as well. Mm-hmm. Another recent development has been a lot of attention being given to the alignment of the knee. So we know that patients who have malaligned knees, if you do just a pure ACL reconstruction on them, then because the limb is still in malalignment, that ACL ligament has a higher risk of re-tear. So there's a lot of interest in trying to advise these patients to also go for realignment surgery of the leg to make sure the leg alignment is normal. So that way they don't get a repeat injury of the ACL. So over the years, there's been a lot of new theories and a lot of new techniques that are coming out. We are learning more and more. All this is an effort to make sure that our patients get the best possible results and they go back to the sports that they love. That's what we want to see at the end of the day.
Okay, this is great information. Thank you, Doctor. For our viewers, if you're interested in speaking with Dr. Ramesh, you can call at +65 6262 3616 to schedule an appointment. You can visit their website at www.avantortho.com.sg for more details. On behalf of our entire team at PhysioActive Indonesia, we want to thank you for tuning in, and we look forward to bringing you more top quality content from leading industry surgeons. Thank you, Dr. Ramesh.
Thank you, Michelle, for the opportunity. Nice chatting with you today.